Now I hand over the forum to our moderator, Dr. Sabina, who is a senior consultant and professor at Sir Gangaram Hospital, New Delhi. And she's also an assessor and faculty with the National Board of Education. She's also national assessor for NQAS and NABH assessor. She has published scientific papers in various national and international journals. And she has conducted conference and webinars, organized various workshops and CMEs. Our special field of interest is primary immune deficiency disorders and coagulation disorders and flow cytometry. So we are very happy to have you here, Dr. Sabina. Over to you.
Thank you, Dr. Mamta. Thank you, Dr. Mamta. And this has been a wonderful Kaho journey, and I'm very glad to learn from a lot of experts in past a few months. And today also we have a constellation of stars, and I'm very excited to introduce our upcoming speakers. So first is Dr. Komal Galani Deshmukh. Dr. Komal is lab director and consultant pathologist, Star Super Speciality Laboratory in Nagpur. She has done her MD and DNB pathology from Tata Memorial Hospital, Mumbai. She has 16 years of experience. She is ex-honorary consultant at RST Regional Cancer Center, Nagpur, had a fellowship at Mayo Clinic, USA in lab medicine. She is trained at CMC Vellore in transfusion medicine. She has been a consultant at SRL Nagpur, and she is presently pursuing PhD course. She has good number of publications in chapters and papers, and her interests include hemato-oncopathology, including bone marrow, flow cytometry, and molecular pathology. So today she will take us to the journey of diagnosis of multiple myeloma. So over to Dr. Komal Galani Deshmukh for our first talk in today's webinar.
At the outset, good evening to everyone. I would like to thank Dr. Sabina ma'am for such a kind introduction. I would like to thank Dr. Aparna ma'am, who has given me an opportunity to be here for this webinar. Quickly moving on to my topic. This is lab diagnosis on plasma cell dyscrasias. Just a word and a quick revision for the PGs. Plasma cells are nothing but terminally differentiated B lymphocytes. What is important is they secrete immunoglobulins. And this immunoglobulins is the reason for the plasma cell dyscrasias or neoplasms. When the word plasma cell neoplasms or the multiple myeloma comes, what we need to remember is just immunoglobulins, because it is these immunoglobulins which are secreted, they're excreted in larger quantities, and it is this because of which we get patients, very many varied symptoms of patients. WHO has classified plasma cell neoplasms into a variety of different types. I will not be discussing this in detail because my topic relates to what are the lab diagnoses, how do we diagnose. Now, any disease, when a patient is diagnosed with a particular disease, most important is history. Once we elicit a good history, we are able to guide the clinician for a good investigation, and then we help them with our lab reports. Now, most of the patients of myelomas present with backache, generally bony pains, backache, and infections are the second leading presenting symptoms. Why I'm stressing this? Because we should know which patients, when should we suspect myelomas, in which patients, and how would the patient come with us with what symptomatology. So backache becomes the first presenting symptom. Next is infections. What happens? Normal immunoglobulins in myeloma patients are suppressed because there is clonal expansion of these abnormal plasma cells secreting abnormal levels of immunoglobulins. So the normal immunoglobulins, the normal infection protection mechanism is diminished, and then the patient is more susceptible to infections. Now, infections in what term? Generally, it is due to Streptococcus pneumoniae, Klebsiella. So patient might land up with pneumonias, with UTIs. Okay. The other short form, which is to be remembered, is the organ damage because of these, again, immunoglobulins. The bony resorption because of proliferating plasma cells leads to lytic bony lesions, osteolytic bony lesions. Now, once there occurs this lysis, the calcium is then eroded, and this calcium circulates in the serum as manifests as hypercalcemia. So the C is for hypercalcemia. The next, there occurs renal failure, the renal impairment due to excretion of these heavy as well as light chains. Then it could lead to unexplained anemia. Again, any bone marrow infiltrative disease, the other hematopoiesis are going to be suppressed. Patient may come with anemia, bi or pancytopenia. And as I said, widespread osteolytic bony lesions. Again, bony lesions more prominent in skull, in the vertebral columns, in the pelvis, long bones, and this can even lead to fractures. And that's why we have bony pains. So in these patients, we are going to suspect. Then there are certain other complications which include light or heavy chain deposition, include amyloidosis, and the symptoms are as mentioned. As I said, very important to remember, osteolytic lesions, punched out lesions, as we say, only in cases of Poem syndrome, there are osteosclerotic lesions. These are beautiful skull X-rays showing multiple osteolytic lesions, punched out, typical, even in the pelvis, here. Now, as I said, in blood, how do we approach, and in the lab, how do we help our clinicians? Basic, routine, good CBC and a peripheral smear will show us, number one, anemia. Number two, rouleau formation. It is very important to know that for rouleau formation, you have to screen your smears on a low power. On low power, you'll be able to see the arrangement of RBCs where they are arranged in stack one above the other, which is called as rouleau formation. You may also see presence of cryoglobulins. Again, it can lead to very high ESR levels. As you see in the biochemical parameters, there is reversal of AG ratio. Why? Because I told you the immunoglobulins are increased, albumin is reduced. That's why this AG reversal. Creatinine, once kidney starts affecting, creatinine levels are on the higher side. Uric acid levels are raised. Similarly, LDH, beta-2 microglobulin, and calcium. Again, I told you hypercalcemia, the word CRAP stands for hypercalcemia. Now, how do we type our immunoglobulins? We do a serum protein electrophoresis to find out when there is an M band or the monoclonal band. Okay, to further we quantitate and to further enlist which type of bands it is, heavy chains, light chains. We do an immunofixation. Also, there are some non-secretory myelomas where they are assessed with the help of free light chain assays. Also, the following speakers will tell you how we prognostically manage the patient and how do we keep the patients on follow-up with the help of these free light chain assays. Similarly, in urine, we have Benz-Jones proteins detection by electrophoresis, immunofixation with and nephelometry. Again, one of the important diagnostic criteria is bone marrow. Why do a bone marrow? Because we have to ascertain the plasma cell percentage, look at the morphology, because morphology sometimes does give underlying clues to underlying molecular abnormalities, as well as IgA or which type of protein restriction, globulin restriction we are able to see. It does give a guide. Again, on biopsy, trifine biopsies, we are able to see the overall cellularity. Sometimes we might get a dry tap in the aspirate and there is a nice focal sheets or maybe clusters of plasma cells in the bone marrow biopsy. So these focal deposits can be better picked up on a trifine, as well as deposition of amyloid, if any. Other tests which include abdominal fat pad biopsy for amyloid, then cytogenetics fish, which are later going to be covered by our coming speakers. Remember one thing, gammopathy, it could be either monoclonal or polyclonal. Routinely, what we see is polyclonal in cases of infections. But here, since we are dealing with myeloma, I would restrict only to monoclonal gammopathy. As I told, polyclonal, as it is common, it's generally seen in infections, connective tissue disease, other tumors. Okay, here what we see in the electrophoretic band is a diffuse broad band. Okay, whereas in cases of monoclonal myeloma patients, there's a single clone, as it says, referred to as M component. Okay, now depending on the quantity of monoclonal gammopathy, is the value less than the specified or is it on the higher side? We categorize the patient as monoclonal gammopathy of undetermined significance or a plasma cell dyscrasia. Now, why I am stressing here on monoclonal is because these patients are, really on near normal side. So very subtle difference between a normal and MGUS patients. And some of these patients, 1% of them progress to myeloma. So early pickup, early detection at this stage of MGUS is really going to be helpful. Okay, there are further subtypes of M-band as we see. Generally, it is the IgG type in 50% of the cases. However, in 20%, we do find IgA types also. There are light chain myelomas. Remember, monoclonal gammopathy can also be seen in NHLs, CMLs, other cancers also. How do we evaluate this gammopathy? As I told you, we do serum protein levels with other electrophoresis immunofixation. With the help of electrophoresis, we establish the presence of M-band, and then we further quantify by immunofixation. This is a typical normal serum electrophoresis. As you can see, this is the albumin. In case of normal patients, albumin is the protein which is maximum, and this is the region where gamma globulins are seen. In cases of M band, this is one band which the gamma globulins fall here, and this is the big spike of M band. See, these are the normal, and this is the M band, the church spiral, which is referred to as typically. Now here you can see in the first electrophoretic gel, you can see there's a light, a faint M band. But in the second one, there's a M band is very strong, very denser M band with a few normal globulins. Here, there is a good M band, but there are no normal immunoglobulins. These are the patients which are more prone to infections, I said. Again, this is hypergamma globulinemia, but this is polyclonal. Okay. There are some limitations of serum electrophoresis, especially when we find it difficult to interpret with faint M bands, missing small amounts of M bands if present. There could be false negative patterns, especially in light chain diseases. We are not able to definitely quantify with this. Okay, for all these, we have immunofixation. This is the immunofixation gel, where it specifies it is of IgA type, IgG, IgA type, M type. These are the most common ones. And the light chain kappa or lambda restricted. Again, the serum is divided into two types, into two parts. The first is for the basic serum electrophoresis. Only when this M band is positive, we move ahead with further tests. We also do urine light chains and BJA proteins. Again, one important point about the serum-free light chain assays is because of its because of the shorter half-life, the changes in these levels is important, and they provide a rapid indication to the response to treatment. So clinicians really find it useful. I understand these tests are expensive, but these tests are necessary. Once we are investing in such high, if we do not have a good diagnosis, we will never have a good treatment. And for good treatment, which costs so much, we should not be thinking on spending for these tests. Bone marrow morphology on the aspirate is very important to pick up plasma cells. We should count at least 1,000 nucleated cells to a certain correct plasma cell count. WHO says, the recent WHO guideline says more than 10% plasma cytosis, along with other features, is a criteria for diagnosing myeloma. Again, bone marrow biopsy will show us sheets, sometimes focal clusters with kappa and lambda restriction on IHCs. Flow cytometry is helpful in many cases, and these days with the minimal residual disease, flow plays an important role. The normal plasma cell phenotype is 138 positive markers. These are the tracking markers. Normally CD56, 58, 126 are negative, whereas the neoplastic cells do show CD56 positivity with the cytoplasmic immunoglobulins positivity. 45 may or may not be positive, and 1920 negative. Again, demonstration of excess of any light chain of ratio around 16:1 signifies a malignant clonal process. There are very many morphologic variants of plasma cells. In practice, we may be seeing very many different morphologies also as compared to the typical cartwheel, which has been described in the books. Like inflamed cells are seen in IgA myeloma. It is said that plasma cells are largest mimickers of the neoplastic cells. Just the way the histiocyte is a mimicker in histopathology, the plasma cell is a mimicker in the hematopoietic cells. Some very good images on low power. As you can see, there are plenty blasts, sheets of of abnormal immature plasma cells, eccentrically placed nuclei, some binucleated forms. Characteristic perinuclear halo basophilic cytoplasm, but mind it, sometimes you may not have such such a book picture like plasma cells. You may have some variations also. So you have to think, you have to correlate with history, with other clinical findings. Okay. See, these are nice plasma cells. And this is the plasma blast. You can see a prominent nucleoli. This is a typical flame-shaped, as we say, flame cells of plasma cell, generally associated with IgA plasma cell disorder, binucleate 1. This is a biopsy where we can see where we can see sheets of plasma blast in abundant eosinophilic cytoplasm. I would again like to stress a bit on MGUS, since this is the commonest gammopathy. It is important to distinguish between myeloma and MGUS. Why? Because patients with MGUS are managed safely without chemotherapy. There was a study by Dr. Ritu Gupta et al. From India, which said that percentage of people, the prevalence of MGUS is 0.83% in more than 40 years, and which is definitely less than as compared to that mentioned in the West. So that is one very good thing. And they again stressed the importance of early detection. Okay, screening. If lab parameters, if we as pathologists could guide our clinicians for early screening, it will really help us picking up such patients. As I said, the M protein levels are less than 3 grams. The marrow plasma cells are less than 10%, but most importantly, they do not have any lytic lesions. No bony lesions, they are asymptomatic. So no organ related, no crab functions, no crab symptoms. Okay, the prognosis is good. As we said, 1% of them per year progress to multiple myeloma patients. And it is very common to misdiagnose the case of MGUS as either multiple myeloma or Waldenstrom's macroglobulinemia. And this is just the statistics. A risk of progression, as I said, per year. Diagnostic criteria for multiple myeloma, just for the PGs. The WHO now says as symptomatic myeloma and asymptomatic or smoldering myeloma. Again, remember 3 things: plasma cells more than 10%, organ-related impairment, which includes CRAB, M component in the serum. The smoldering myeloma includes marrow plasma cytosis, which is more than 10, and or either or a M component more than 3. But there's no organ impairment in smoldering myeloma. MGUS, the levels of M component and plasma cells both are less. Again, no lytic lesions, same thing. Now, just to re-emphasize, for myeloma, you have to remember the triad of 3 things: marrow plasma cytosis, osteolytic lesions, and our favorite monoclonal gammopathy. These 3 things. The other osteolytic lesions could be seen in hyperparathyroidism, metastatic carcinomas, primary bone tumors. Marrow plasma cytosis and monoclonal gammopathy could also be seen in chronic infections, autoimmune disorders, liver cirrhosis, rheumatoid arthritis, Hodgkin's disease, aplastic anemias. Just a word about plasma cell leukemia, where there are more than 20% circulating plasma cells in the peripheral blood. These patients fare badly. We do see sometimes primary plasma cell leukemia, patients lining up with leukemia even before diagnosing them as myeloma. Prognosis is extremely poor. A word about the non-secretory myelomas, which have absent M component in the serum and urine. We do immunofixations and free light chain assays for such patients. These patients are generally 10 years younger as compared to normal myeloma patients. Renal failure occurs is very uncommon in them because definitely because of absence of monoclonal light chains. Just a word about osteosclerotic. Generally, myeloma is osteolytic lesions, lytic lesions. Only in case of OM syndrome, it is osteosclerotic lesions. Plasmacytomas, it could be either solitary plasmacytoma of the bone itself, localized to any of the bones, especially spine, ribs. It's a single bony lesion, basically, referred to as plasmacytoma of the bone. The same thing if it occurs in extramedullary lesion, generally seen in upper air passages. We have seen cases of extramedullary plasmacytoma in the intestine as well. They could be either anaplastic plasmacytoma, plasmablastic lymphomas. a typical plasmablastic lymphoma, plasmablastic morphology, very high-grade cells, prominent nucleoli, mitosis. Again, lymphomas will have LCA positive. They'll express LCA. CD20 is negative. And this is the case I was talking about, extramedullary plasmacytoma, LCA negative. It's showing a nice lambda light chain restriction. Just to summarize the criteria for diagnosis again, for MGUS, the protein levels should be less than 3 grams, clonal plasma cells less than 3 grams, and no lytic lesions, no crab symptoms. For smoldering myeloma, the protein levels are more than 3, clonal plasma cells are more than 10. Again, there are no endocrine-related or tissue impairment. Symptomatic myeloma will have evidence of CRAB. Non-secretory myeloma will show plasmacytosis. The absence of M protein in the serum urine. Solitary plasmacytomas could be of the bone or the extramedullary type. They are other distinct entities. Just a revision of lytic lesions, M-band plasmacytosis, clonal gammopathy. I would like to thank the audience for the patient hearing, and the questions will be taken up at the end. Thank you.
Thank you, Dr. Komal, for this excellent talk on plasma cell dyscrasia, not only covering the very diagnostic cases, but also the dilemmas that we face each and every day in classifying these patients and the varied presentations that multiple myeloma creeps in.